Hi, good morning, everyone from New Haven. It's our real distinct pleasure to be here. I know that people are joining from around the world, so it might be good evening, good day. My name is Emily Wong. I'm an internist and associate professor at the School of Medicine at Yale, and it's a real pleasure to be here on the kickoff of a new center, the SEICHE Center, which is a interdisciplinary center between the Yale School of Medicine and the Yale Law School, where we're really trying to tackle how best to improve the health of individuals, families, and communities that have been impacted by mass incarceration. And this, we hope, will be one of a number of webinars and opportunities to learn, build our community around the SEICHE Center, really focusing specifically here today on the intersections between the correctional healthcare system and the healthcare system in the community. And so I'm going to go ahead and turn it over to the Director of our Educational Initiatives, Dr. Lisa Puglisi, who's going to orient you to the webinar today, the speakers, and what we have in store.
Thank you, Emily. Again, good day. Thank you for joining us. Lisa Puglisi, I'm a practicing internist and direct our clinical work at our transitions clinic, caring for people who are leaving correctional systems and coming back into the community. We work in a team that is made of previously incarcerated people who have been personally impacted by the carceral system, and then researchers, physicians, public health experts, and the like. So we're just really happy to have you joining us. We have a unique group of people with lots of innovative ideas on our panel today, and we are excited to all learn together. I'll say, the overarching aims for this webinar are to identify innovative strategies to prevent entrance of COVID-19 into correctional facilities in the first place, and then to mitigate its impact on people who are incarcerated and staff who work in correctional systems once it's entered. Additionally, we'd like to highlight opportunities and challenges in correctional and public health partnerships. So to that aim, I encourage us all in the audience to be really thinking critically through ways that public health systems and correctional systems can be collaborating, what are barriers and facilitators to that collaboration as we think through these innovative ideas that are presented to us. A few small housekeeping things. So one is that we will try to stay on time to the best of our ability. If you have questions, we very much want to see your questions. Please use the Q&A box down at the bottom of your screen to enter them, and we will then kind of collate them and share them with the presenters. Additionally, we will have presentations, and one presenter who will be speaking in Spanish today. And so for the English-speaking audience, and you can use the interpretation button at the bottom of your screen. It's not working yet because our interpreter is still joining, but when we need to, that will be available. So you can translate Spanish to English. And then por los participantes que se hablan solamente español, tenemos una interpretación hoy. Puede usar el botón de interpretación que está abajo en su computador. That was my very bad Spanish communication around using the interpretation function. But that I will cue people in as to when that is ready, when our interpreter is on. Okay. Also, we try to use person-first language. It's kind of core to our mission of centering our work around the needs and health and wellness of people who have been incarcerated or impacted by the carceral system. So to that aim, we try to say things like people who have been incarcerated, people who are currently incarcerated, instead of stuff like inmates, prisoners, felons, or the like. So this is not a webinar about perfection. We will all trying our best, but just sharing with the participants in your questions if you can also try to be using person-first language. Great. Anything that I've forgotten? I don't think so. So without further ado, let me turn the mic over to Doug Dretke. Doug is the Executive Director of Correctional Management Institute of Texas. located in the George J. Beto Criminal Justice Center at Sam Houston State University. CMIT serves training and professional development needs of correctional professionals across a broad spectrum of corrections, as well as serving as a resource for research needs and technical assistance. Prior to CMIT, Doug served for 26 years with the Texas Department of Criminal Justice. He began as a correctional officer and advanced through the ranks throughout his career. He received a BS in Criminology and Corrections from SHSU and a Master's of Public Administration with a concentration on criminal justice from Texas A&M Corpus Christi. He is active with a number of state, national, and international professional associations, past president of Texas Corrections Association, and he received the Dr. George J. Beto Hall of Honor Award in 2009, recognizing his significant achievements to the correctional profession. Doug.
Thank you very much, Lisa, and good morning, good evening to all of you from across the globe. It's an honor to say a few words this morning as we get started with our webinar. I want to thank Dr. Puglisi and Dr. Wang for their initiative in putting this together with Yale University. So this morning, my time, evening for many of you, I represent the International Corrections Prison Association, our executive director, Manon Bisson, from Canada, and our president, Peter Severin, from New South Wales in Australia. And the ICPA has, at the very outset of this pandemic, put together a COVID-19 task force to see how we as a international association of correctional prisons association could serve as a resource to the global correctional community. One of our initiatives was to facilitate what we call information exchange meetings, which are really discussions among correctional professionals from across the world to talk about the significant challenges that they're facing with COVID-19, talk about their experiences, and then to share lessons learned, best practices, as each of them tackled this complex issue in the prevention and control of COVID-19 within our prison settings. And as you all know and can imagine, this has been an incredibly difficult time for our correctional staff, from our line officers to our leadership who are responsible for the management of prisons and jails, and especially for the men and women who reside under our supervision, living within our prisons and jails. And it was very interesting to us, despite a country or a jurisdiction's size, geography, type of system, COVID-19 protocols have been substantially similar across our globe, as well as the efforts to mitigate the impact of the coronavirus infection. The use of PPEs, elimination of face-to-face visitation, cancellation of work and treatment programs, all creating much more difficult conditions for those who are incarcerated within our prisons and jails. Different systems have been impacted differently. Some systems experiencing no active cases, others systems experiencing tragically high numbers and deaths. But during our exchanges, we listened to a number of very innovative practices and efforts by prison management, from focuses on enhancing communication, breaking down silos between departments, focusing on hygiene and cleanliness within our prisons, to much larger system focuses, coordinating with the different components of our criminal justice system towards actual reductions of prison populations. And over again, we listened to some very positive initiatives, practices, and innovations that we believe and hope can have a substantive impact on helping to transform corrections towards a healthier environment into the future. So in my time, I want to take a few minutes just to talk about some of the things that we heard. And I absolutely am not suggesting that this represents all of our prison and jail jurisdictions and countries, but it was some very positive things we heard from a number of them that then we as a global community, I think, can focus on as this webinar is doing. How do we continue to grow those very, very important initiatives? So we heard from a number of people talk about the innovation of employees themselves, correctional staff looking at how can we do things differently, how can we do things better, to the staff who have been caught working in these conditions, gaining a confidence in their capacity to work through this level of crises, and a correctional force all focusing on the same mission of making our prison environments a healthier and safer place for both the staff and the people residing within our prisons and jails. One of the really, I think, exciting things we listened to over and over again was this recognition how critical communication was. Over and over again, we heard leadership talk about their efforts and initiative to communicate with the population of men and women within their facilities. One specific story, one warden, some systems we call them governors, some systems we call them directors, superintendents, had an annual monthly meeting with his council of men and women who represent that population. And he recognized that that wasn't speaking to enough of them. So he on his own began a weekly gathering of over 70 men who lived there to help talk to his entire population about why we were doing what we were doing to help keep the population safe. The feedback he was getting was substantive and a practice that he plans to keep into the future. And we heard this over and over and over again about these enhanced communication efforts, as well as with staff. And as you all know, most of our prison systems are paramilitary structures, hierarchical, that are often not very conducive to very strong communication efforts. And so I think we heard some very positive things. Technology has played an incredible role. The utilization of tablets for prisoners to use them to communicate with their families. Over and over again, we heard how different systems looked at Skype technologies, tablet technologies, all kinds of technologies to allow this critically important activity of visitation with family and friends. And the same thing, those systems that have tablets, they were able to use them to communicate to the men and women within their population, to send out medical information, to send out some level of programmatic activities, utilization of technology for distance virtual learning to replace some of the programs and so forth. So the technology that is being used, I think, is absolutely going to be a part of us and continue to build that capacity within our systems. Those of you who have backgrounds within facilities recognize there's often been very strong silos: treatment, security, medical. Over and over again, we heard how our systems within our facilities are all working as one. And I always liked one specific statement that I think will be into the future. We are joined at the hip with our medical professionals and agencies. And that was seen as a positive and something that would go forward. The enhanced focus on hygiene within our environment, making our facilities cleaner and safer places. I think that's something as a positive that we will see continue to go. And then from a larger systems perspective, focusing on enhancing emergency management plans, policies, procedures, pandemic now as a key focus in those plans to continue to combat what we're dealing with, but also to be better prepared to deal with it in the future, and using science to help make appropriate decisions in the population and with their staff. And then the last piece would be this really, we heard some exciting coordination efforts from some systems and jurisdictions, working with law enforcement, working with their judiciary, working with their medical agencies and professionals to actually and literally reduce their prison population. And one interesting statement we heard in this effort: for the first time, government is paying attention to us. That's potentially exciting and very important towards this effort that so many of us around this globe are working on, is to reduce our prison populations. So those are a very quick overview, but we hope that somewhat sets the stage for some of the very exciting things that we are going to hear and learn about through the rest of this webinar. So with that, thank you very much.
Thank you, Doug. And you know, that reminds me of something I had wanted to say before, and that was a great sort of laying the groundwork there. You know, there have been countless webinars on COVID and pick your, you know, interests. Certainly in terms of COVID and correctional systems, there have been numerous. Our goal with this webinar was really to be forward thinking, right? And to say, we recognize that people on this call from across the country and across the world have experienced COVID in their correctional systems in a host of different ways. There's a large spectrum from 0 cases in Australia to the US, where 30 of the 50 top outbreaks have been in correctional systems, right? And it really runs the gamut. As we start to consider getting out of just a reactionary phase globally, our interest is in bringing forth ideas that would help systems across the world think with anticipatory management of how do we prevent, plan, you know, for 24 months down the road, as we expect that this will be a rather long ordeal. So thank you for that, Doug. And I'm going to turn next to Dr. Lloyd, who we are so grateful for joining us. It is almost 11:30 p.m. his time. And because of that, and us wanting him to get his rest after this, we will take questions directly after his presentation so that he can get some rest. So Dr. Lloyd is an infectious disease physician with both clinical and laboratory research expertise. He is the head of Viral Immunology Systems Program at the Kirby Institute for Infection and Immunity at the University of NSW, Sydney, Australia. He is a National Health and Medical Research Council of Australia Practitioner Research Fellow, and he leads a research team studying the epidemiology, pathogenesis, and treatment of hepatitis C infection. He has been heavily involved in the Australian response to the SARS-CoV-2 virus, particularly for the prison sector. Professor Lloyd was awarded an Australia Medal for his work in establishing infectious diseases and hepatitis services in NSW prisons, and for his clinical research achievements in infectious diseases. So thank you, Dr. Lloyd, for joining us, and I will turn the mic over to you.
Thank you very much, Lisa, and thank you very much to your colleagues for organising this webinar, and congratulations from down under in your new centre, which I wish the best to. There can be no doubt that the intersection of law and health is a key element of the prison, so I'm sure it's going to do well. I'm going to try and spend the next 10 minutes just to talk to you a little bit about some of the efforts that have happened across Australia, but focusing a little bit in the prisons in the state where I work, which is New South Wales, which is where Sydney is located, which is illustrated on the slide here. And in particular, to overview for you the state of the art in the Australian epidemic. Actually, I'm going to describe the correctional system just to familiarise you, tell you a little bit about how we're travelling in Australia, with the take-home message being we're doing reasonably well, and then to talk to you about a project which was commissioned with some of the members of my research team who are mathematical modelers to guide the introduction of prevention measures in the correctional centres in Australia, and now is currently focusing on guiding the rollback of those prevention measures, hopefully in a safe fashion. So the Australian correctional system has about 110 individual adult centres. That's not including what we call juvenile justice centres, and not including police cells where people pass through very transiently. Our incarceration rate is about 220 per 100,000, which is not as high as some of the states in America, but it's up there in the league tables. Our prevalent incarcerated population is about 43,000. So our country has 25 million people, and we incarcerated about 80,000 individuals per year, with 43,000 or so in prison at any one time. Our prisons, I might mention to you, are synonymous with both jails and prisons. We don't distinguish between those two. And our, what we call remandees, so not yet sentenced individuals, constitute about a third of the whole of the incarcerated population, with the remaining 2/3 being sentenced. And like many systems, they're predominantly male. And sadly, here in Australia, we have about a 3% Indigenous community population. So this is Aboriginal Australians. And about 28% of the inmate population are of Indigenous background. So we heavily over-incarcerate our Indigenous folks. Our prison sector is almost exclusively public sector. So there are 1 or 2 privatised prisons, but very, very few. They are run uniformly by the state. There are 8 states or territories in Australia, and the individual prison systems are run by the state authorities, with the exception of a sole federal prison, which usually incarcerates people caught importing drugs into the country, which is located in Canberra. We do have variations on the correctional custodial authority to health authority arrangements. The system where I'm going to talk to you a little bit about is those 2 organisations are separate but co-locate. So there's a separate health authority that reports to a Ministry of Health, and a correctional authority that reports to a justice ministry in the state where I work. With regard to the COVID epidemic in Australia, you would have to say that we've had a very strong and remarkably unified public health response very early in the piece. So I think as early as February, we had border closures, controlling the incoming passengers from overseas and imposing quarantine or restricting absolutely. And then very strongly enforced physical distancing, business, school closures, ramping up of health system capacity. We have quite good socialised medicine here, but our intensive care unit and ventilator capacity was proactively enhanced very early in the epidemic, and lots of efforts to isolate and very proactive contact tracing. As a broad statement, I would say of the 8,000 odd cases that have happened in Australia, there would not be a single one that has not had exhaustive contact tracing for all the contacts identified. In the graphic on the right, the main element is that up and down curve you can see in the middle column, which shows that in and around March we had a pretty typical epidemic. And then largely since that time, it's been very well controlled, and we've been in the phase of de-escalating a lot of control measures in the community I'm talking about at the moment. at the tail end of that graph, actually, there's a little upwards peak, which is our getting with the crowd and having a second wave, which is just actually restricted in one state in Australia, the state where Melbourne is located. A good proportion, the majority actually of all of our cases in Australia have come from overseas. And so that's been an opportunity for us to keep tight control of the epidemic in the community. And then, as Lisa said, in the prisons. Although it would be fair to say in the upslope of that epidemic curve, so I think the peak is sort of mid to late March, in the early upslope of that epidemic curve, my research group was approached by the Correctional Authority in the state where I work and the Health Authority jointly to say, we need some modelling to tell us what we should do to control the anticipated outbreak in the prison sector. And so to achieve that, we searched the globe for a readily available model and came upon Recidiviz, which is, you probably know, is a US-based organism, a non-governmental organisation, which is proactive in the policy sense in trying to reduce incarceration within the United States, largely by data gathering to try and influence policymakers. So even by that time, so by mid-March, Recidiviz already had a draft Excel spreadsheet model. And we thought this was a great opportunity. This is a population model, so it's a compartmental model. But the great part is it's very user-friendly. So it can be taken by any policymaker or healthcare provider, and the local jurisdictional data can be entered and estimate the epidemic future and model the trends that have happened in the past. It's a pretty typical infectious diseases model, designating populations of individuals that are susceptible, exposed, infected with various stages or categories of disease, recovered, hospitalized, or fatal. And we built upon the Recidiviz model to better include not only the inmate population, but all the correctional staff, the healthcare staff, and what we've called other non-essential staff, like visiting lawyers or contractors, electricians, or whatever, and also to model family visitors and their potential impact. We've used some terminology here that I'll refer to again. So we've designated, in looking at the disease progression rates, we're very keen to ensure we correctly identify individuals who have premorbid characteristics that might make them more vulnerable to accelerated or more severe disease and thence fatal outcome. So we have data that we've put into the model, and we do model vulnerable populations versus non-vulnerable populations. And then we track movements between prisons and between community and prisons. And we paid a lot of attention to designating contacts, which we've defined using a pretty standard definition of 1.5 meters. I can't remember what that is in feet or yards, but 1.5 meters and 15 minutes to be what you might call a plausibly clinically significant transmission contact time. And so each individual in the model, or each population in the model, is given a probability of having a contact. The actual model, I've just got a screenshot or two here to just give you a sense of it. This is the inputs page, and all of the setup of the inputs page basically has a set of parameters characterizing, for instance, the local hospital community, hospital capacity, the intensive care capacity, and then details about the prisoner population, some details about the healthcare worker and correctional worker population. And then it allows entry of an infected individual or more than one individual into various contexts into the model. And then the second part of the input page actually describes scenarios where in the first instance we modeled the counterfactual scenario. That's where there are no interventions in place. And then a whole series of interventions that I'll describe a little bit further. that, a little bit like Doug was saying, are probably many that you're familiar with, but including all sorts of control measures. And so that we can then model having no interventions or one or many individual interventions, or all added together. And so those interventions, which were being discussed by corrections at the time we were developing this model and informed our inputs into the model, were, as Doug had flagged, I think, a reduction in the prisoner population. There was a legislation passed in our state to allow early release, and active efforts to defer sentencing hearings to avoid bringing too many people into prison. And all of that had the net effect of reducing the actual prisoner population. In the state where I work, there are 40 or so prisons, and the prevalent population was about 14,500. And at the peak of the epidemic, it got down to about 12,500. So about a 20% or a bit less reduction in the prisoner population, and hence better physical distancing within the physical facilities. Quarantining at reception, so individual sets of individuals arriving, kept in individual sets of cohorts until 14 days of quarantine. Isolation of proven and suspected cases, PPE that we've spoken about, and then reducing family visitors and non-essential staff members, or thermal screening, or both. So all of those interventions we've modelled in using this, in conjunction with the correctional health authorities, we've modelled, and I'm just going to present a touch of data to you to give you a sense of it. With data, for instance, from a single exemplar metropolitan Sydney prison, which has about 1,000 individuals who are incarcerated, of whom 1 in 5 is in that vulnerable category. It's manned by about 170 correctional staff and a surprisingly modest number of healthcare staff. And there's a fair bit of turnover in this particular centre, about 30 individuals coming or going every day between prisons or from the community. And then in the model, you can see that we start off by just introducing a single newly incarcerated inmate and no control measures versus various versions of the control measures. So the black epidemic line on the right tells you about the infected inmate population, the hospitalised, the recovered, the mortality. And each of the other coloured interventions, or going down to the lowermost bar, is the implementation of all 4 of those interventions. And so you can see that each individual intervention has a good justification for it, and in combination, the sum is better than the individual parts. And so all of those measures actually were implemented, and I'm confident have been critical to maintain control of the epidemic in the community, but not in the prison centres in New South Wales and across Australia. These 2 graphs now illustrate the impact on correctional and healthcare staff of the epidemic in the prison. So this is transmissions to the healthcare staff and their contacts being no longer able to attend work. And so you can see very rapidly the staff population becomes decimated, either with active disease or with need for isolation. And that obviously is another major logistical exercise for correctional and health authorities to ensure that adequate staff are available. And so numerically, these data just illustrate that scenario, those scenarios for you. This prison, you remember, has just over 1,000 inmates and about 180 staff. And you can see here that over a 3-month period in this modelling, there were a very large number of infected cases, almost 2,500. And each of the interventions in the rows, you can see, reduces those numbers. And all 4 interventions really give you pretty reasonably tight control of the epidemic and dramatically reduce the hospitalisation and intensive care demand and the deaths associated with the epidemic in the prison context. I'm going to spend the last moment just saying one or two things to you about, it's really, to be honest, a work in progress, because for mathematical modelers, of which I'm actually not one, that model is nice, but it basically averages population. So it's relatively, it's very user-friendly, but very unsophisticated in a modeling sense. And so we've moved on to adapt a model we actually recently published about hepatitis C transmissions, which is actually an individual-based model. So this model actually takes every individual. So in our situation, 14,500 individuals in the New South Wales prisons at any one time. And it allows us to model the course of events that will happen to every individual over time, and allows much more individualized perspectives, not only of the inmates, but the prisons and the wings and the organizational structures that influence transmissions. And several of the parameters are similar to those I've already spoken about, although the additional one that's noteworthy here is that we also model in more detail the movements, what in our local parlance we call the trucks, where 14 or up to 20 individual inmates are transferred jointly in a truck from one centre to another. And that takes sometimes a day, because we cover 800,000 square kilometres in our correctional system here in New South Wales. And so that provides a concerning potential opportunity for transmission. And we're also modelling in some more detail other transfers to courts and hospitals and so on. Strategies. And so I just put one graph of data from this model, which just shows you immediately, it's much more fine-grained in analysis. And this graph just presents an illustration of some of the prisons broken down by security classification. And you can see that the epidemic is much more multiphasic. This is modeling the whole statewide prison service. So there's a multiphasic distribution of the epidemic propagating from prison to prison, transported by infected individuals or potentially staff members crossing the boundaries between individual prisons. And then finally, I wanted to show you this graph, which is looking more to where we are currently, which is looking at rollback of measures. And this is now looking at the growing pressure of reintroducing family visits, for which there's a lot of demand, both from families and from inmates in custody. And you can see that with our very low prevalence in the Australian community, the probability on the left of having an individual family member visit and subsequently transmit is pretty low. So the epidemics can get established, but they're pretty delayed. And on the right-hand side in the red bar is introduction of family visits, but with control measures retained in place. And you can see there's a degree of reassurance there that family visits could be reintroduced, provided the within-prison control measures are kept in place. So I'm going to finish there and just particularly acknowledge Amy, Neil and Richard, who are actually the modelers, and all the great reference group from Corrections and Health that worked with us on this project. Thanks very much.
Thank you so much, Dr. Lloyd. And there's one question here in the chat room. So the question from Caroline Watson is, how has your model of clinical vulnerability been differentiated? Is there a matrix of multiple risks, or is it based on individual diseases / comorbidities? Yeah,
great question. Actually, the spreadsheet, if you get a chance, have a look for it. It's on GitHub. I can actually send round the link, Lisa, because I think I forgot to put it on the slides there. But it's public domain, available on GitHub, and it has several spreadsheet pages that describe all of the assumptions which are continuously being updated. So, for instance, on the vulnerabilities, we regard our Indigenous community as vulnerable across the board because they have significantly higher morbidities. And then for the remainder of the community, it's a combination of age and pre-existing morbidities that are informed by the literature, such as pre-existing lung disease or pre-existing cardiovascular disease.
Great. And one last question. Can you please explain the control measures in place to allow the family visits to resume?
So in that last slide that I presented, actually that is introduction of family visits with no control measures. So that means family members coming and meeting with their family member who is an inmate without additional measures other than the ones already in place within the prison. Obviously, I don't know that anybody in their right mind would really do that. Presumably thermal screening, PPE, hand washing. So, but there's a significant degree of reassurance that it's feasible to do so.
Thank you. And with our last minute, so to the public health lens and speaking of release, I know you have had no cases. And so there has been investment in your country in modeling for scenarios which have actually yet to occur, right? And the ultimate testimony to anticipatory management.
Yes.
But have you taken, can you comment on whether you have taken any released people in anticipation of potential outbreak?
Taken any released people?
So
meaning...
I'm sorry, have you taken any measures to release people based on your modeling?
Yes, as I mentioned, Lisa, there was in the state where I work in New South Wales, there was a legislation passed at very short notice to allow early release for those with minimal residual sentence and who hadn't committed too serious a crime. And so the combination of deferring of sentencing of individuals who might be incarcerated and early release is what's brought about that 15 or 20% reduction in the prisoner population.
Great, thank you for highlighting that. I think that's important for us all to think about. There are no other questions in the chat room. Dr. Lloyd, thank you so much for your time.
Thanks so much, Lisa. I'm going to retire gracefully.
Great.
Good on you.
And we're having a very slight change in plans because we're still waiting for our interpreter. I apologize for this little hiccup, but that's okay. We will keep moving. And we had tried to have our two modeling presentations a little bit separated so as not to overload the modeling conversation, but we appreciate Giovanni Malloy for being very flexible, and we will have him go next and then hear from the Dominican Republic afterwards. And so for full disclosure, and so that everybody knows, Giovanni is a PhD candidate who has actually been working with our lab. So we are collaborators in another modeling study that he will be presenting. Giovanni is like I said, a PhD candidate at Stanford University in the Department of Management Science and Engineering. He develops computational models to improve decision-making in healthcare using complex networks, machine learning, data analytics, and economic modeling. Applications of his work include emerging zoonotic, neglected, and sexually transmitted communicable infectious diseases. Giovanni, take it away.
Good morning, everyone, or good evening, depending on where you're joining us from today. Thanks very much, Lisa, for that wonderful introduction. So as was mentioned, I'm coming to you from Stanford University today. So behind me is our engineering quad. Much like right now, the sun is rising over the quad. So in spirit, I would be presenting from there. Today, I'll be joining from my home, just like many of you today. So I'll be presenting about the effectiveness of interventions to reduce the transmission of COVID-19 in a large urban jail. Excuse me, there we go. And this is joint work, as Lisa mentioned, with Professor Lisa Puglisi, Professor Margaret Brando, who is my advisor here, Tyler Harvey, who is also a member of the lab, and Professor Emily Wong. So just to give everybody some background here, I want to provide the motivation, and I know that a lot of you joining the call probably are very intimately familiar with the motivation I'll be describing. But people who are incarcerated are obviously in very high-risk environments for the spread of COVID-19. And this includes the lack of ability to implement social distancing, just because of factors given the built environment and the structure of daily living, as well as inconsistent testing practices between facilities. So just like in the community at large, very much so, correctional facilities, we're still learning the best strategies to mitigate COVID-19. So one of the things that we like to do in our lab is pull some motivation directly from the news. So recently, you see Time Magazine reporting on U.S. prison, the number of cases in U.S. prisons, local news outlets in Texas, California, North Carolina. So this is really a problem that extends, as many of you know, across the United States and across the world. So what is our research goal for this particular study? Well, we really wanted to look at how do interventions that are not accounted for in some of the CDC guidelines, such as mass release, increased selling, and asymptomatic testing, reduce the spread of COVID-19 in a large urban jail. So we worked with a really great partner, an anonymous jail in the US, who provided us data so that we could try and use a model to answer this exact question. So as I just alluded to, our methodology, I'll give you a brief overview, but we created a model. And so this model is a stochastic dynamic transmission model. So that means we're introducing probability distributions for each one of the parameters that go into our model. And we calibrated this model to the reported incidence of people who are incarcerated and the staff members of this particular jail. So the jail produced reports of daily incidents. Here's how many new cases of COVID-19 we have today. And we calibrated our model to that data. So as I just mentioned, the jail had both daily incidence reports and a census. And by that, I mean, basically they provided the total number of people who are incarcerated each day, as well as the number of staff, so that we could get a sense of the change in the level of population. So now I'll briefly discuss the structure of the model. And so the model itself will be describing the disease states of COVID-19, which will likely be familiar to you all. So first we have the S state, which stands for susceptible. And so these are people who are uninfected, who have not had the disease, and as the name suggests, they could potentially get COVID-19 disease. Then we have what's called the exposed state. And just to clarify, in terms of modeling, exposed really means infected with the disease, but not yet infectious. And when we have exposed individuals, they can either become infected with symptoms, and when they have symptoms, we assume that they are identified as being infected and moved into a quarantine area, which we consider to basically mean that transmission is cut off. This person will not be able to transmit the disease to anybody else within the jail. And from quarantine, they may become hospitalized. So that's that box that is marked with an H, or they may recover, or in this case, I suppose, be removed from the system. And from hospitalization, they may also recover. The other option, if you don't develop symptoms, as many of you are probably familiar with from the news, is to be asymptomatic. So somebody who's infectious but presents no symptoms of COVID-19 disease. And from that state, we also consider recovery after a certain number of days. So the particular jail that we worked with was, we believe, incredibly proactive in their response to mitigating COVID-19. And so just to illustrate that to you all today, I'll go through a list of some of the interventions that they took. So they undertook symptom screening, suspension of tours and gatherings, suspension of in-person visitation. For newly arrived people who are incarcerated, they established separate receiving tiers so that they would not be mixed with the general population immediately. They implemented mass release, single celling. They had a COVID-19 paid leave policy for staff. They required the use of surgical masks for staff. They had on-site testing available for officers. They had masks for people who are incarcerated. And they had testing of asymptomatic people who are incarcerated. And these interventions obviously didn't happen all right away, but they all kind of happened over the course of the outbreak. And as I mentioned before, the three that we are most interested in were mass release, single celling, and testing of asymptomatic individuals. And the reason that we are interested in these is because we believe that these would be very high impact interventions that don't necessarily fall within the listed CDC guidelines. So what we did to address these three interventions within our model is we broke down the outbreak into 4 separate, what we call intervention phases, based on the timeline of the interventions provided to us by the large urban jail. So in phase 1, we have our initial outbreak in which the jail is responding with things like suspension of in-person visitation and other kind of basic sanitization measures and following CDC guidelines. In phase 2, they're continuing to do all of these things and also implementing mass release of the people who are incarcerated in the facility. In phase 3, they're continuing to do the CDC guidelines, mass release, and they begin increasing the proportion of people within the jail who are single-celled. So that is, they have their own one person assigned to one cell. In this case, a lot of that was accomplished by moving, basically removing one person from a double occupancy cell and reducing the number of people within the jail. And finally, in phase 4, they began the process of testing asymptomatic individuals within the jail. So this is kind of how we're going to break down the course of the outbreak, and I'll be referring back to phases throughout the presentation. So how did we calibrate our model? Here we basically calibrate to the incidence of COVID-19 within the jail, as I mentioned before. And so the graph that you're looking at on the slide in front of you, on the x-axis, we have the day of the outbreak. So our time horizon of the data set that we have is a little over 80 days. And on the y-axis, we have the incidence of symptomatic cases. So that's the number of new symptomatic cases per day. The blue dots that you see on the graph are the reported incidents by the data set provided by the jail. And as you can see, the reported incidence is highly variable. For example, a little bit before day 20, you have one day where you have a little bit around 20 cases, and then the next day it's 67 cases. So what we did to kind of smooth out this curve was we did a simple moving average, a 5-day moving average, which is this green line, which, you know, it's not the smoothest curve you've ever seen, but it was our calibration target in lieu of calibrating to these blue dots. So something a little bit smoother. And then finally, our resulting model is shown with the red line. So this red line indicates basically what our model says will happen once you've implemented all of these different phases. So now I'm going to talk a little bit about the results of our model. And so the first thing that we look at is when we're calibrating, we are actually calibrating the transmission rate of COVID-19 within the jail. So the transmission rate is basically a measure of the strength of how many infectious contacts will somebody who is infected have within the jail. So just to kind of show you what's important in this picture is that you see on the x-axis we have the different phases as I mentioned. So phase 1, the initial outbreak. Phase 2, you start mass release. Phase 3, you add single celling. In phase 4, you're adding in asymptomatic testing. And then on the y-axis, you see we have this value beta, which is really the transmission rate. And this is the number that we're calibrating to. So we have all of these other parameters in the model, like how long you're infectious, those kind of things we've gotten from literature. And then using our calibration targets that I mentioned before, we're coming up with this measure of the strength of infection or the force of infection, which we call beta. So you can see with at every phase, beta is reducing. And that's really the important takeaway from this graph here. And the other important takeaway is just by how much is the transmission rate being reduced by each one of these different interventions. So when we go from the initial outbreak, which is strictly CDC guidelines, to implementing mass release, we see a reduction in the transmission rate of the disease of around 56%. When we add in single celling, increasing the amount of single celling, we again see a subsequent reduction of around 50%. And then finally, when we add in asymptomatic testing, which allows you to basically isolate or quarantine somebody who may be infected that you previously had no knowledge of their infection, we reduce the spread of COVID-19 by an additional 73%. So you can see that each one of these interventions had a significant impact on that transmission rate. So another way to think about this that you may have been hearing about as you're reading maybe the news or in different papers about this topic is the effective reproduction ratio. And for those of you who are not familiar, the effective reproduction ratio is a measure of the expected number of secondary infections you can expect that arise from an initial infection. So if you have one person who's infected, how many additional individuals will they likely infect? So as you can imagine, if that number is higher than 1, if I'm infected and I infect more than one other person, then the outbreak continues. So that's an incredible threshold that we want to keep in mind. If that number is lower than 1, then you'd expect the outbreak to eventually die out. So here we have this graph of the effective reproduction ratio over time. So again, we have our time horizon on the x-axis. So we track the outbreak, in this case, over 200 days, which is basically just to say until our model, until we reach 0 additional cases in our model. And then on the y-axis, we have the effective reproduction ratio, which, as you can see, is relatively high. So here in red, with this wide credible interval range, is phase 1, which is the initial outbreak. So as you can see, for example, the effective reproduction ratio starts out very high and quickly drops. And there'll be a reason for that that I'll show in the next slide, but essentially the outbreak is like each person is infecting so many people that the outbreak dies out rather quickly. So here, as a benchmark, I provided the basic reproduction ratio, which is the exact same idea, but with the basic reproduction ratio, you're thinking about how many additional individuals would somebody expect to infect in a completely susceptible population. So if I'm infected and I enter a room that is filled with people that are completely susceptible, how many people will I infect? So we estimated that before the implementation of mass release and before the implementation of single celling and before the implementation of asymptomatic testing, this number was a little bit higher than 8, which is very high. Then, as you can see, we get the significant drop when we add in mass release. So if you were to back this out and say, okay, let's get the same initial starting position with mass release only, with the CDC guidelines plus mass release, then you would drop the basic reproduction ratio to around 3.5. Then as we add in single celling, you would again significantly reduce the basic reproduction ratio, and you can see that it is also a significant drop in the effective reproduction ratio, that R of T measure. And finally, when we add in asymptomatic testing on top of all those, we kind of get below our magic threshold number of 0.45. You might be looking at this graph and say, well, gee, with all of these interventions, we eventually get to a state where we have an effective reproduction ratio below 1. But the important takeaway is basically that the way that you reach an effective reproduction ratio below 1 before you're adding all of these interventions together is that you're infecting so many people that there are not enough susceptible individuals left. So I will now show you something that may be a more relatable statistic, which would be the number of cases, of symptomatic cases that you would expect in each case, or in this case, we could talk about cases averted. But for some people, maybe the effective reproduction ratio is not quite as relatable. So here we have our outbreak time horizon extended out until all scenarios reach 0 incidence. So here we have on the y-axis the number of new cases, or the incidence of symptomatic cases. So as you can see, this is kind of a really good visual of this mantra that has become so ubiquitous of flattening the curve. So when you have the initial outbreak with CDC guidelines, you have this huge peak very early on, right? You get to day 30 or so, and you've got 250 cases on that day. Whereas when you implement just mass release, you're peaking a little under 100 and at day 45 or so. Then you add single celling and you're peaking at under 30 or something like that, and at day 60. And then finally in this purple line is what we actually model happened in the jail. So as you can see, they potentially averted many, many cases here. And so just to acknowledge that, in the initial outbreak scenario, we would estimate a little over 3,500 infections of both staff and people who are incarcerated. When we look at adding in mass release, we still have 2,500 cases. When we're adding in single selling on top of that, almost 1,500 cases. And then finally, when we have all of those plus asymptomatic testing, we have almost 650 symptomatic cases. And for reference, over the same time horizon, the anonymous jail had around 800 total cases, symptomatic and asymptomatic, that they reported. So you can see here that each of these interventions averts many, many cases, which is really important. So I just want to conclude with some final thoughts. I wanted to make mention that despite the impossibility of social distancing, COVID-19 can be mitigated in jails and prisons, as you've seen from the slides before you, doing things like mass release, single selling, and asymptomatic testing. And I also want to make mention that in our model, we are assuming that all of this transmission is arising from internal transmission, and our system is limited to this jail, right? So in some cases, we may be slightly overestimating the transmission rate or the effective reproduction ratio, but the big take-home message is that each of these interventions has some relative risk reduction that is real and tangible and achievable, and this model is a good demonstration that these three intervention strategies are indeed effective. And obviously, that is in addition to the recommended CDC guidelines. So as a final note, our full paper is available on medRxiv right now. So it's not yet peer reviewed, but it is available on medRxiv. And we hope that it will be available elsewhere very soon. So with that, I will take any questions that you may have.
Thank you so much, Giovanni. For the sake of time, I think we're going to do most of the questions. We will save some questions for the end, but I will share with you one of the questions from our chat room.
Absolutely.
Okay, so Olivia asks, do you know how many people or the proportion of the population detained at this jail who were released? I think the proportion would be helpful.
Yeah. So after the mass release started, they were releasing about 1.4% of the population per day, and the population is several thousand. So you're looking at releasing around 50 people per day, roughly, once you start the mass release process. I don't have in front of me the exact number of people that were released, but basically what we did was we looked at the percentage of the population per day that was released, and hopefully that answers the question sufficiently.
Thank you. I'm going to save some of the questions for the end while we try to get the Dominican Republic on. So thank you, Giovanni, if you can stay with us. Okay, so a little announcement as these things go. We had a little snafu with our interpreter who is not on the call, but who we had planned to have on. And so we are really excited to have colleagues in the Dominican Republic joining us. And as you know, I think that everybody chips in emergency situations. Dr. Butler de Lister, who is I believe a sister of one of the staff, is joining us to translate. So this is amazing. Dr. Butler de Lister, thank you so much. We are really grateful for you. And now I'm just going to orient us. If this works correctly, I got to do one thing here to make it work. If this works correctly, then I should be able to have us have interpretation. Okay. Give me one moment. Okay. Yay. So we will give this a little try. Thank you for your patience and for bearing with us. Dr. Butler de Lister, are you able to use the join in the interpreter line? Oh, I'm not able to hear you. Oh, I think I'm not able to hear you because I put you doing Spanish to English, so I think it might be working. So for those in the audience who are English speaking, for those in the audience who are English speaking, to hear the Spanish presentation in English, just simply go to the bottom of your screen under interpretation, and you should be able to select Spanish to English interpretation. Please put something in the Q&A box if you're unable to, but that should work. Let's, we will give it a try, okay? So without further ado, we are really excited to have, I'm hearing somebody, but I don't know where they're coming from. Okay, I think I'm just muting them for a quick second. So just to introduce our colleagues from the Dominican Republic, we are really, really honored to have General Tomas Holguin La Paz and Dr. Annalise Roa, who are the director and medical director, respectively, of the Penitentiary Services of the Dominican Republic, overseeing the country's prison system. Today, they will be sharing with us the Dominican Republic's effort to incorporate fogging into their country's largest prison, La Victoria. And now I'm going to unmute them. Oops. Let's see. General, if you can just, se puedes empujar el botón de unmute.
Ya, puedo hablar.
Comienza
a hablar.
¿Ya?
Sí,
Entonces, tratamos con esta...
comienza a hablar en español.
Sí, muy buenos días para todos y mi saludo a todos los colegas de la ICPA y gracias a ustedes por pensar en República Dominicana para que pudiéramos compartir con ustedes esta experiencia que ha sido pues el manejo de el COVID-19 dentro de la población penitenciaria dominicana que, como ustedes saben, tenemos
General.
nuestros penales prácticamente sobrepoblados.
Okay. General, the general just said hello to everybody and he's honored to be part of this. The penalty of La Victoria
en algún momento ha llegado a tener sobre 9,000.
La Victoria is a penitentiary that has housed over 9,000 interns.
La principal preocupación nuestra era
the main worry of ours was that the virus would enter the prison, that was so overpopulated. Just like the colleague that preceded us, we elaborated norms of how to confront this epidemic. And that once it was in the penitentiary, that we could actually work quickly to resolve. They elaborated a protocol so that the DR government could respond to this.
Ese programa nuestro que elaboramos vino a ser como una secuencia del protocolo que había elaborado el Estado Dominicano como tal.
The program that we elaborated was in sequence with what the Ministry of Health had developed for the government.
Una primera fase de logística.
Holguin, alto el fuego, Holguin, general.
Todo lo que tenía que ver con lo que fuera necesario para enfrentar el virus. Todo lo que fuera logística de trabajo.
We had to,
Un momento, por favor, ¿puede andar un poquito más lente?
can you hear me? Can you hear me for a second?
No.
No.
Un poquito más lente porque doctora Butler necesita traducir un poquito más.
Simultáneamente.
¿Está bien?
Okay.
Okay.
Un poquito. Gracias. Muchas gracias.
Look, you have to tell them to stop
Okay.
so that I can translate that bit. And
Okay. Y general, ¿se puede
detener.
detener un poco a veces por hacer doctora Butler, hacer el translation?
La traducción, sí,
La
ya él
traducción.
entendió ya.
Ok, gracias.
Ok. Bien, como ustedes pueden apreciar ahí, ese es el penal de la Victoria.
This is the penalty of La Victoria.
Parte frontal,
This is the front entrance.
¿verdad? Ahí tenemos parte del personal administrativo.
We have part of the administrative personnel there.
La imagen. Aquí fue que tuvimos el primer caso
There's where we
de...
had the first case,
Nos vimos ya enfrentados al problema en sí. Ya,
when we had to face the problem itself.
como ustedes pueden ver aquí, esto ocurrió el día 4 de abril.
This was
cuando
April 4th.
el Ministerio de Salud Pública y
The
nosotros
MOH.
la obligación de intervenir el penal ya con el virus adentro.
In collaboration with us, we had to intervene. The virus was already inside.
Del penal, y esto obligatoriamente nos llevaba a suponer que las demás áreas también
It
iban a
was in
ser.
one of the areas of the penitentiary, but we
Entonces,
supposed that it was everywhere.
que hicimos ese día nos permitió sobre la marcha poner poner en camino el protocolo o el programa que ya habíamos elaborado y que está encaminado a enfrentar ya el problema como tal. Ya habíamos
We were able
agotado
to put in place the protocol that we, and the program that we had designed.
un programa que tenía que ver con la preparación y adquirir todo lo que fuera la logística para enfrentar el problema.
You know, and set up all the logistics to confront the problem. And then the second part was
Nos
training.
sorprende la entrada del virus preparado en una parte, pero realmente nos sorprende la entrada.
The
porque no-
entrance of the virus actually surprised us in the part of training. We had the protocol for what we were going to do, but the training part was not set up yet.
Tener que enfrentar nosotros mismos junto con el personal paramédico, junto con todas las instituciones involucradas, y nosotros entonces no vernos solamente como directores, sino como actores ya
We
responsables.
became just part of the team of all the organizations that were there collaborating.
de lo que nos imaginábamos.
And it just happened before we imagined.
A que sobre la marcha nos viéramos obligados a capacitar nuestro personal, a enfrentar una
While
situación
implementing this program, we had to be training the personnel.
no teníamos ni siquiera idea de cómo lo íbamos a enfrentar. Y más el temor de un recinto que es se construyó para 2,000 personas y que tú tienes
We
8,000
were very fearful because this precinct was built for 2,000 people and we had over 8,000.
y era un panorama bastante preocupante.
We were very worried.
¿Qué hicimos nosotros?
What did we do?
De inmediato a tomar pruebas rápidas donde
We started doing rapid tests.
y le tomamos rápida a todos los internos de esa.
We did rapid tests to all the interns.
La cantidad que estaban infectados, ahí tuvimos la primera muerte, ahí tuvimos dos muertes en esa.
We had the first 2 deaths that week.
Porque realmente la misma situación de sorpresa nos llevó quizá no a cometer errores.
They were very sudden. We were very surprised. We committed some mistakes because we weren't really aware of what the symptoms would be. The symptoms were very strange. They were totally asymptomatic. And then they would have this area, acute respiratory distress. We had the first casualty. And this made us all be alarmed. And we had the advice of the Ministry of Health. And the recommendation was to isolate those who were positive, even if they were asymptomatic.
Un espacio fuera del penal, habilitamos un hospital, prácticamente un hospital.
So we refurbished a place outside the penalty, outside La Victoria. It's like a center for isolation, exclusively for these interns that were infected, even if they were asymptomatic. We went through all the areas of the penitentiary with a rapid test, and we tested everybody. That allowed us to separate immediately those who were infected, even if they didn't present symptoms. Simultaneously with this testing,
mañana, tarde y noche.
We implemented a 24/7, a permanent strategy at the penalty to disinfect all the areas.
De manera permanente. Entonces, enfrentamos el virus directamente con una agresividad.
So we faced the virus directly, very aggressively. You know, as the virus was aggressive, we were also aggressive.
Y eso entonces nos permitió a nosotros tener un virus que de manera agresiva penetró, pero así mismo lo enfrentamos nosotros.
The virus entered aggressively, and that same way we confronted it.
El virus penetrara a las áreas mucho más pobladas del penal, donde hay un área que tenemos 2.400 internos, y el temor nuestro era que el virus entrara a esa área.
We were able to curtail the path of the virus to the more densely populated area of the prison, where we had 2,400 men. That management that we had of permanently being disinfecting the areas and fumigating the areas. We did it in the morning, at noon, and in the afternoon. And the next day we would do the same thing.
Permitió que el virus no caminara en el penal con efectos.
That was what we understand, stop the virus from spreading throughout the whole penalty area.
Pero nosotros vemos los resultados excelentes desde el punto de vista de la agresividad del virus y con
The
la
results were very good, considering the aggressiveness of the virus. We thought that what we needed to do was stop the chain of transmission. And using the isolation wards that we set up outside, following, you know, the Ministry of Health, MOH parameters and guidelines.
Otra cosa que tomamos en cuenta fue el tema de aislar los pacientes vulnerables que por un tema de enfermedad, por un tema de edad, eran vulnerables.
We also isolated those individuals who, because of their age or pre-existing conditions, were more vulnerable.
Nos permitió rápidamente a esos pacientes aislarlos.
Those patients we isolated We took them to another place. Regardless of whether they were sick or not. Anybody who had the age or pre-existing conditions that made them more vulnerable, we would take them to another precinct where they have 230 interns right now. They have another one with 280 of them.
Y obviamente hemos recuperado más del 60% del personal que se infectó.
We have recuperated over 60% of the personnel that got infected. We had over 1,200 interns that got infected.
Entonces, los que permanecen aún en tratamiento y todavía en condición de infectado, siguen en esa condición, pero ya nosotros con una experiencia vivida, con un manejo adecuado, ya sin el temor, sin
Those who are still infected, we are still handling now with less fear because we have understood the way to manage this. You know, once we were over that first initial impression that impacted us.
El protocolo de salud que hemos implementado.
The most important thing is to maintain the protocols that we have established. It is endorsed by Public Health Ministry and also by WHO.
El gran porcentaje nuestro de recuperado es excelente, excelente. Ya, el tratamiento que implementamos ha sido
the treatment that we implemented has been very effective. 95% effective.
A nosotros entonces manejar ya los casos en cualquier penal, no solamente en La Victoria, porque tenemos otros penales que se nos han infectado.
We have other penitentiary sites that are also infected and we've been able to handle it. La Victoria has been our teaching area. It's where we have learned how to handle this.
Muchas gracias, General. Tenemos preguntas, si podemos. Una pregunta sobre esta desinfección. ¿Era solamente por los trabajadores o también por personas encarceladas?
No, era para todo el mundo. Fueron túneles de desinfección que se colocaron en las entradas de los penales. La idea era evitar, en principio, que el virus penetrara, porque obviamente donde la amenaza principal...
He didn't understand your question.
Sin embargo, el interno era el que menos lo usaba porque estaba confinado a estar dentro. ¿Qué conseguíamos con esto? Que todo lo que entraba al penal, de personal administrativo, personal de abastecimiento,
everybody who entered the prison would have to go through this tunnel, and that was the disinfection. I think he's answering something different than what you asked.
Okay.
You were asking something else. You were asking if the interns were actually involved in fumigating.
No, who was getting fumigated. So
okay, everybody who entered the penitentiary went through this tunnel.
Okay. Entonces, un tema importante que también manejamos nosotros conjuntamente con el protocolo y ya finalmente fue el tema de la visita que hemos logrado, obviamente con los internos, en base a un criterio de concientización de
We have also been very successful with the visits.
Y mantener la población penitenciaria bajo un control y sobre todo diciéndoles a ellos que su salud, que su seguridad.
We've done a lot of gracias and conscientization.
Okay, muchas gracias. Muchas gracias, señor. Paramos aquí y esperamos preguntas, ¿ok? Muchas gracias, General.
Okay, muy bien.
Muchas gracias por su presentación y esperamos.
Encantado de esta oportunidad.
Gracias a usted. Thank you so much,
Gracias a
Dr.
ustedes.
Butler, Lister. We so appreciate you coming on very last minute to help us with translation. We are really indebted to you.
It's okay. My pleasure. I appreciate very much Holguin and his team and the work they're doing.
Great. So I don't have any specific questions in the chat room right now about the fogging per se, but perhaps if some come up, we can ask in a little bit or email them as well.
Okay.
Many thanks. I'm going to move us along. Muchas gracias, General.
Gracias a ustedes. Muy amable.
Okay, and so now if you want to, you can, if you don't need it translated anymore, you can go to your translation button and just from English, you can click it off. And thank you so much, Dr. Butler. Okay, I'm gonna move us along. Again, there's a little bit of a change in the itinerary. We don't have Director Chambers-Smith on with us right now that I can see. So I'm going to jump forward so that we can hear about the role of mobile applications within corrections in the age of COVID-19. And to speak about this, we are joined by Doctors Kelly Collins and Richard Garfein. Dr. Collins is a trained infectious disease epidemiologist with a PhD in global health from the University of California, San Diego, and an MPH in epidemiology from San Diego State University. Dr. Collins has extensive experience evaluating digital health interventions among vulnerable populations around the world. As a UCSD pre-doctoral fellow prior to becoming executive officer of Sure Adhere in 2015, Dr. Collins spent 5 years learning from TB control programs and their patients that were using video directly observed therapy in practice. She is the co-author on a number of peer-reviewed articles focused on improving adherence to anti-tuberculosis treatment using digital applications. Since leaving UCSD's VDOT research team in 2015, Dr. Collins has led the successful commercialization and scale up of Sure Adhere's VDOT technology to 18 different countries, 300 local jurisdictions and clinics in the US, and has contributed to a number of international projects to scale digital adherence technologies globally. She is joined by Dr. Garfein, who's an infectious disease epidemiologist, educator, healthcare innovator, who seeks to understand the cause of disease and translate that understanding into impactful solutions. Dr. Garfein earned his PhD at Johns Hopkins and an MPH at San Diego State University. He is an epidemic intelligence service officer and epidemiologist for 7 years at this Centers for Disease Control and Prevention before joining the UC San Diego School of Medicine faculty in 2005. His research focuses primarily on airborne and bloodborne infections, often associated with health disparities and substance use, including tuberculosis, HIV, viral hepatitis in the US and abroad. His research on digital adherence technology over the last decade informed CDC and WHO guidelines on the use of telehealth for remotely monitoring patients with tuberculosis. Such technology has relevance today for COVID-19 monitoring and patient support, and I turn the microphone over to the both of you to teach us more about that.
Well, thank you, Lisa. Can you hear me? All right, and can you see my slides?
Yes, perfect.
All right, excellent. Wow, good job putting all the technology together. So thank you very much for this opportunity to present. I'm going to start off the presentation and give a little bit of background about what video observed therapy is, pertaining to tuberculosis primarily, and then I'm going to hand it off to Dr. Collins, who can give an example of how it's being used in Haiti as well as in Washington, D.C. So just a quick disclosure. I'm a professor of medicine at UC San Diego, but I'm also the co-founder and chief science officer for Sure Adhere Mobile Technology, and Kelly Collins is our chief executive officer. And we're a software company that provides commercially available video observed therapy. However, what we're presenting today is purely generic, and it doesn't matter whether you use SharedHere or any other provider of video dot, that all of this information should be relevant. So just to start out with a little bit of background, tuberculosis is an infectious airborne disease, airborne infectious disease that kills more people than any other infectious disease worldwide. The good news about TB is that it is curable with antibiotics. However, adherence has to be maintained at a very high level in order for the treatment to work, as well as to prevent ongoing transmission to other people and to prevent the acquisition of drug resistance. Once there is drug-resistant TB, the treatment becomes much less effective, much more expensive, and much more toxic. And so it's very, very important to maintain adherence from the very beginning and not to be too lax with it. So because of this, the World Health Organization and other health agencies like the CDC advocate for something called directly observed therapy. This is and directly observed therapy is a process by which a healthcare provider or a trusted designee visits the patient every day and watches them actually swallow their medications. And the idea is that this sort of patient support and constant vigilance encourages patients to maintain high adherence. And also, if they stop taking their medication, it's determined very quickly, and remediation methods can be put in place to encourage the patient to continue taking their medication regularly. So the benefits of directly observed therapy have been shown to be that it increases adherence, which is a good thing, and by definition, that also decreases the amount of acquired drug resistance, the amount of treatment failure and relapse. It also helps to establish rapport between the patient and the provider to sort of help the patient to understand that this is a joint effort to help the patient to complete treatment. And the nice thing is it also can allow for intermittent dosing. If treatment is conducted regularly, patients may be able to take the medications every other day as opposed to every day. However, there's a lot of challenges with travel to go to a clinic or for the provider to go to the patient every day. It also involves a lot of cost in terms of that transportation and manpower to implement. It requires a lot of counseling and support to encourage that patient. And it also requires sort of a differentiated care model. What's important here, I think, is that with COVID-19 now, the process of a patient and a provider getting together in the same space to observe medication ingestion actually can put both the patient and the provider at risk of COVID infection. And so this is becoming actually much more difficult to implement DOT globally because of the concerns about transmission of COVID. So there's a number of different technologies that have been developed and actually implemented around the world over the past decade to sort of try to get at the same benefits of directly observed therapy without using technology to facilitate this. And so there are things like the 99 dots application, which is where patients text in a phone number every time that they take a pill, and it records that the medications were taken, so providers know whether or not the patient took the medication. There's also a WISE pill box, which contains medications, and every time the pill box is open, it registers an opening, and so it also alerts the providers that the patient presumably took the medication. And then there's some fancier technologies like ingestible sensors, where a microchip is placed on every tablet, and when the patient swallows it, the microchip sends a signal to a patch that they wear on their side, and it indicates that the medications were swallowed. And there's other things like pill bottles and artificial intelligence, and finally video observed therapy that have been are being deployed. And so what we're going to focus on here today is the video observed therapy part. And I just want to note that there are two different ways to conduct video observed therapy. One is like a FaceTime call. It's where the patient, or a Zoom call like we're on today, where the patient and the provider can both be online in real time and have this conversation and observe the medication. And then there's what we call asynchronous video observed therapy, which is where the patient makes a recording and the provider watches it asynchronously. And so let me just give you a little description of what that looks like. So up at the top left here, what the patient does is they'll have an application on their phone, on a smartphone, that starts up their camera, and they put it in selfie mode, and the patient is given in advance some instructions about what to record. And so they're instructed to hold up each tablet in front of the camera so that it can be visualized, say what the tablet is, put the tablet in their mouth, swallow it, and continue that process until all the medications are taken. When they're finished, the application will encrypt the video and send it to a secure server where it sits waiting until the health care worker comes into the office, pulls up the video on a computer website using a web browser, and then they can watch the video and see what the patient did and then document what they saw. And so that's the process of video dot. And so this slide here just shows you some of the evidence that has been obtained from various trials that have been being done around the world that indicate that video dot actually does increase adherence. It's highly acceptable to patients and providers, and it actually reduces the cost of providing directly observed therapy. So based on these studies and some others, the World Health Organization now recommends video observed therapy as a replacement for directly observed therapy when it is feasible, meaning that the technology is available and the personnel are available to use it. And so since then, there's been a number of studies that have been implemented around the world. Here's just an example. Kelly, had, in the introduction, you had mentioned a bunch of the studies that Kelly is working on right now. But these studies are being funded by UnitAid and the Stop TB Partnership. Our colleagues at Everwell are involved in several of these projects where they've actually combined video dot along with 99 dots and the Wise Pill application into a single platform so that the healthcare providers have options of what technology they would like to use. And so just briefly, what are some of the benefits of using video observed therapy? One is that it provides the patient with autonomy, so they can decide when and where they're going to take the medications, rather than having to wait for the healthcare provider to show up or to go to a clinic. They can take the medications at the time that is most appropriate for them. And the reason this is important for tuberculosis is that the number of pills is quite high. It could be up to 10 to 20 pills per dose. And oftentimes these pills have side effects such as nausea or upset stomach. And so taking the medications with a meal can really help to ameliorate that. So by having that sort of freedom to take the medications at the time that's appropriate for the patient can also help to improve adherence. Video dot also provides differentiated care. And this is where persons can receive individualized information through either text messaging or having access to information through the smartphone that they're using for video dot to learn more about their TB care and treatment. And then finally, it can provide a real-time connection with their provider. So the patient can use their phone to contact their doctor if they're having side effects, if they need more information, if they are having a problem with their treatment. And they can do that either through SMS text messaging, telephone call, a mobile application, or FaceTime, for example. And bot also provides benefits to the providers. And this could be by providing automated alerts or reports to the provider to let them know which patients are and are not taking their medication. And this is a real advantage to healthcare providers because when patients are adherent, there really isn't a whole lot more the provider has to do. And so what they want to do is they want to focus on the patients that are non-adherent. And so by quickly figuring out which patients are not taking the medications and which ones are, they can really focus their attention on the patients that need the support the most. And the video dot or video observed therapy is also beneficial at the national and subnational levels for national TB programs because it provides all this information that's being put into the system is available immediately to TB program directors to sort of see how different jurisdictions are doing in terms of their TB care, in terms of adherence, and in terms of completion of treatment. So finally, my last point I just want to make is that there are some barriers and challenges to implementation of video observed therapy. One is that the patients have to have access to a smartphone and connectivity. And so that may be a barrier in some places. And we've had examples of where health departments have provided patients with phones because it actually is more advantageous to use video dot than in-person DOT, and it's worth the cost of the phone. Also, patients need to be willing to use it and find that it's acceptable, although we haven't found too much trouble with that. The providers need to have a computer that they can access the videos from, and it's important that this process fits into the normal workflow of that clinic. And then also what we find that is crucial is that if the providers are receiving information about which patients are taking their medications and which ones are not, they need to be able to act on that and be responsive, because just getting that information and not doing anything about it is really useless. And patients figure out pretty quickly that if they don't take their medications and nobody follows up with them, they know that nobody's watching. So it's really important that providers do respond appropriately with their patients. And then finally, from the NTP, National TB Program perspective, there needs to be capacity to utilize this data and provide programmatic support for healthcare providers that are using it. There's questions about where the data are hosted. Is it in country? Is it outside the country or in the cloud? And then finally, is this data going to be integrated with existing surveillance systems that are operating in the country? So these are all situations that we've dealt with, and we'd be happy to answer questions from the group on how things have been done in other locations. And at this point, I'm going to pass this off to Kelly so that she can give you some examples of how video observed therapy is being used in other locations.
Great, thanks so much, Rich. So I'm just going to say hello and then turn my video off because my bandwidth is a touch short. But I'm going to talk to you all today about how we've worked with Health Through Walls, which is an NGO based in Haiti that provides healthcare in prisons context. And so we worked with them on a pilot study last year to look at video dot. And I'm also going to talk about an example where we have implemented VOT as a tool for COVID isolation support. And so what we really want to do is bring this full circle to both the prison context and to speaking towards the COVID theme of this webinar today. So go ahead and switch slides, Rich. So speaking to the Haitian context, and these slides were developed by Dr. John May's group at Health Through Walls. So thank you very much, John, for allowing me to use these beautiful slides today. We're thinking about providing care in Haitian prisons. There's a number of challenges, both in the societal context and also within the prison context. So some of the historical challenges among prisons in Haiti, one is major overcrowding. So overcrowded correctional facilities creates a ripe environment for both TB transmission and other diseases like COVID-19. Additionally, a third of prisons in Haiti lack a full-time health staff. So many of these individuals, incarcerated individuals, do not have access to healthcare at the prisons where they are located. And as such, TB care was not previously offered to persons living in these remote prisons in Haiti without healthcare staff present. And so when a patient was identified with TB, they were often not transferred to a new facility until they were very ill. And as you can imagine, there's many barriers and challenges associated with transferring very ill individuals to, across a rugged country, into a treatment site or into a new prison. And so Health Through Walls team really wanted to try to address some of these challenges and actually provide TB care at these remote prison sites, so patients did not have to be transferred and that the disease did not proliferate inside the prison. Additionally, their team faced with the rest of the country in 2019, civil unrest in Haiti that prevented the movement of citizens, including prison staff and healthcare staff, from going to work, from going to school, going to stores and medical clinics. And this happened for weeks at a time. And at the same time, prisons in Haiti remained on lockdown during these periods of unrest. And so no one was allowed in or out. And it really hindered the work of Health Through Walls team to provide care at these prison sites. So next slide. So their group sought to, again, as I said, mitigate some of these issues. And so Health Through Walls team implemented an intervention at 5 prison sites and 3 control sites around Haiti. They had correctional officers held video-enabled tablets, and the patients recorded themselves taking their medication. And then the staff at central facilities, the Health Through Walls staff, actually reviewed these videos, confirmed adherence, and in the event of a missed dose, a correctional officer would actually report that dose at the local prison. And then they did conduct an evaluation around this, and they looked at surveys and collected demographic information on acceptability and acceptability data. And also both patients and correctional officers participated in this evaluation. Next slide. Next slide. And in terms of some results, so VOT was initiated successfully at all 5 intervention sites, and median adherence among these sites was 85.7% on VOT only, but when we looked at VOT plus co-confirmed doses by correctional officers, adherence was at 100%, so really great to see treatment completion at these sites. There was a number of implementation challenges around the unrest and also maintaining a continuous network connection at the prisons in order to upload videos. But some really great takeaways from this initial pilot was that VOT enabled medication and treatment to continue at prisons despite the unrest that was happening around the country. VOT facilitated by correctional officers allowed the provision of TB treatment in these low research correctional facilities, and VOT enabled continuous patient monitoring and treatment follow-up at historically challenging sites. So I think some really nice takeaways from using a telemedicine approach to support infectious disease among these prisons. So the next example that I'm going to talk about very quickly is VOT isolation support for COVID-19. So SHIRT here is actually working in the US right now quite widely, and many of our health departments use our platform for tuberculosis care, but also we have started supporting COVID-19 cases and contacts during home isolation. And so persons identified with COVID-19 or as contacts of COVID-19 patients are supported by local health departments. And essentially the patient or contact will take a video of themselves every day, reporting in over this 14-day isolation period, any temperatures, any reported COVID-related symptoms. And those videos are uploaded and to the back-end website where health staff can view the videos and then again action on the information on those videos. So public health staff can follow up with contacts and determine, do they need to be referred to testing or to care. And so I think in this context, to wrap up our presentation today, when we're really thinking about this in prison settings, so go ahead to the next slide, Rich. We see that there's potential role of VOT within corrections facilities during this era of COVID-19. So the first area is that we see an ability to reduce contact between correction staff and incarcerated individuals. So potentially supporting medication adherence via these remote telehealth tools rather than doing in-person mouth checks, for example, and increasing contact between correction staff or healthcare staff and incarcerated individuals. And then also potentially facilitating COVID-19 symptom monitoring for contacts for both correction staff and incarcerated persons given an outbreak in the facility. So I think there's potential there as well. And then lastly, I think what we've seen with Health Through Walls experience is that telehealth gives us the option of enabling care in remote prison sites where health care staff are not usually available. And so a tool like VOT can enable, medication adherence support. It can enable, telemedicine style visits. And again, this could help to reduce contact amongst healthcare staff and potentially infected individuals. So I think there's a lot of potential here. And just to sort of wrap this up, Rich and I are not experts in the prison setting, but I think we've seen a Health Through Walls team teach us, that telehealth tools are relevant in prison settings where I think traditionally it might not be something that's looked at off the bat as an option. So we just want to say thank you and open it up to some questions.
Thank you so much. If you can stop your share, that would be great. And I'll let Emily field some of the questions. I'm having a hard time opening it, but I'll start with one, which is maybe a summary and then a question. So I heard, in thinking of how public health systems have a role in proactively mitigating entrance of COVID into correctional systems and then helping mitigate. I heard Dr. Garfein mention provision of phones. So in places where that technology is not accessible to incarcerated people, I heard of an example with the TB video dot of having health departments of public health or local health systems providing the technology. So I think that that's something that really interests me and is a good thing for us to think about. And then I don't think you mentioned it, Kelly, but I'm also hearing, I think another potential in COVID might be increasing access to medical care for people who are either isolated or who have trouble accessing it, even here in the US where there are health systems inside, that doesn't always translate into access. And so I wonder what you think about the ability of this technology to increase access of incarcerated people to health information, ask questions about symptoms they may or may not be having, and to increase their kind of knowledge and self-monitoring and self-efficacy in caring for themselves and monitoring for their own symptoms.
Mm-hmm. Thank you, Lisa. I'll start and then I'll pass it off to Kelly because I'm sure she'll have some ideas as well. In terms of providing patients with a phone, I think that there's some experience with that being quite effective. In the United States, we actually have what people refer to as the Obama phone. It's a fairly inexpensive smartphone that people who are low resource can apply for and get a free phone to use. And it's been found to be incredibly helpful in connecting people, especially people who are homeless or transiently housed. They might not necessarily have an address that people can get a hold of them at. And so just sort of connecting with healthcare services and social services and family and friends, it could be a real benefit. Also, as you mentioned, people can get access to information about their disease. So if somebody has questions about what the side effects that they might be feeling and isn't sure if it's time to call the doctor, they can maybe look some information up. There's also a lot of applications available that provide information for patients on TB as well as other diseases. So I think there's some benefit there. And the last thing I'll just say is that there's been, if John may be able to speak to this, but I heard that there were a few examples of where the patient was leaving prison before they completed treatment. And by having a phone that they can take with them, they were able to actually complete treatment post-release. And I think that there's some interest in trying to do something like that here in the United States as well for our detainees who've been released. And so in that case, the modest amount of money that it would cost to provide somebody with a phone can really help to ameliorate a lot of more expensive problems that can occur down the road by not having a phone.
So I'm hearing that that's also an opportunity for Department of Public Health or community health system collaboration and cooperation with correctional health systems in really kind of taking over after release and helping to monitor people for symptoms after release and connecting them to care. So I think that's a good thing for us to all think about, and thank you guys both for your presentation. If you could stay on, there will be some more questions at the end. I want to, for the sake of time, I want to move us along, and we're absolutely thrilled to have a large team present with us next on modular systems. This team is multidisciplinary and is the ICPA ACA planning and design team composed of experts in architecture, planning, design, correctional leadership, and correctional medicine. The team has extensive experience in both the US and Haiti, as well as advising many other nations around the globe. Many individuals on the team are members of local, national, international associations and have provided guidance to organizations such as the UN, UNAIDS, and International AIDS Society. For sake of time, I'm not going to read everyone's bio, but we would be happy to send them out. And I know that the team is overseen by Stephen Carter, and Mohammed Hassan will be starting off the presentation. So to you all, thank you for joining, and I'll let you introduce yourselves and take it away.
Cool. Are you able to hear me? Yeah. Well, first I want to thank the Yale Justice Lab for this opportunity to explain what we are doing in terms of an architectural response to a crisis situation in Haiti involving COVID. We appreciate the presentation that Dr. Collins just gave, which provides some background to the situation in Haiti. The next slide, as Lisa's mentioned, the International Corrections and Prisons Association and Health Through All share a similar mission of wanting to look at the promotion of ethical and effective correctional practices out of a deep concern for the rights of those who are incarcerated to provide a healthy environment as possible. Next slide. To introduce the team, we'll give you a brief history, and I'll do that, followed by Jim Bate, who is a senior architect with Dewberry out of Washington, D.C., to speak of the infection control and architecture. Then we will look specifically through Dr. John May, Dr. Edwin Prophet, and Catherine Duverger, who are on the ground in Haiti, about how the process is being managed in the National Penitentiary. Andy Couples and Mohammed Hassan, who are with the DR group in Southern California, will present our solution, and then we'll wrap this up with Robert Borax out of Canada, architect with Parkin, who will speak to the future of the prison health care. Next slide. Just a little bit of the history of what we are doing. Back in 2009 at the Barbados conference of the International Corrections and Prisons Association, the UN Department of Peacekeeping Operations, which is now the Department of Peace, approached the board of ICPA to ask if we could develop a temporary solution to post-conflict situations. So we assembled a team from ICPA, ACA, of planners, architects, contractors to develop a plan. We had a number of meetings in New York and other locations. And our team worked in a pro bono type environment for approximately 6 months to prepare documents. In January of 2010, as many of you know, there was a devastating earthquake that changed the priorities away from a rapidly deployable prison to one that could be actually applied in Haiti. We made site visits there in 2010 to determine the feasibility of applying our solutions, some examples of which you can see around the slide here, of using shipping containers. We found that there were many logistical problems associated with transportation of the containers, some site preparation issues, not to mention economic and political constraints that delayed implementation of the first rapidly deployable prison in Haiti. But in January of this year, my good friend, colleague, Dr. John May approached us again to say Health Through Prison Walls was going to be gifted 10 modules from the UN mission in Haiti that was closing, and asked if we could develop a temporary solution using those 10 modules. So the rest of the presentation, we're going to describe to you what we have done in the last 4 weeks to try to meet this requirement. Jim Bate is going to speak now to the issue of infectious control through architecture. So Jim, I'll give it to you.
Okay, thank you, Steve. COVID is definitely a new disaster that has struck us, and it's been a challenge to respond to it in a quick manner. Next slide. Next slide. Large public spaces have been converted into makeshift clinics so that the population can be segregated from the balance of the population for the folks that are critically ill. These are some images from New South Wales, their COVID response, where they've sprung up these very secure and sanitary isolation units for individuals. Next slide. It's much quicker for operations to respond to this tragedy than obviously physical response through architecture. So what we've seen here in the States is that population reduction, which has really been a positive thing. There are some positive things that have come out of this. The U.S. has a very high incarceration rate and a real focus on trying to get that down. So there's been a big movement for at-risk populations to be released to home incarceration or home supervision. Anyone near-term sentence release, we've moved very quickly to get those folks out, in an overall reduction in intake population to make sure that only folks that really need to be held are held prior to trial. Facility lockdowns, Anthony Lloyd from Australia went into pretty good detail about that. Similar operations here, minimizing visitation, use of remote appearances, and a lot more reliance on video visitation. And then best we can, the infection control to isolate the infected populations, increased hygiene, disinfectant of the areas. And we're seeing a lot of institutions actually where the inmates are making masks and using those internally as well. Next slide. The longer term impacts that facilities and architecture can actually begin to address that we see down the road. And we think, again, positive, a continued focus on population reduction. Bail reform will be enhanced to get folks that can't make bail, not forced to be incarcerated until their trial comes up. More appropriate sentencing, alternatives to secure housing for those that are found convicted, and a reduction and hopefully elimination of dormitory housing as a means to house people, and a movement more towards individual rooms, smaller populations, and then a more focus on medical treatment in the facilities. Access control, a little concerned that there might be a higher reliance on remote visitation. Video visitation has a place, much like our meeting today, where we can see face-to-face with people that we wouldn't normally be able to see. There's nothing that replaces the direct contact with loved ones and family members, and we're concerned that there may be a movement away from that. And also a movement to more self-contained housing units, which where all the services are brought to the individual. There's pros and cons to that. It's a less normalized environment. It's something we want to keep a close eye on as we move forward. We also understand that there'll be a lot of focus on indoor air quality, reviewing air take requirements and ways to mitigate pathogens in the air for return air. Next slide. That I'd like to, next slide, please. With that, I'd like to turn it over to Dr. May, who is with us from Health Through Walls and has been incredibly helpful through this entire process. Dr. May.
Yeah, hi. Thank you, Jim, and everyone. So these are some pictures from the Haitian prison system, which is among the most overcrowded and under-resourced prison system in the world. Our NGO began work there more than 20 years ago. mostly through volunteers from the US, folks who worked in jails and prisons here who see how we can assist with the prison system there. Since that time, we've grown to many other countries, but in Haiti in particular, now there's a staff of more than 100 persons who are Haitian physicians and nurses working there in the prisons, but yet these same conditions remain. So the challenge of COVID has suddenly created a huge problem with these very overcrowded conditions. There's no place to isolate or create quarantine units of those who are contained, and that's why we reached out to this group that's developed this very innovative and creative plan for us. Next, we'll have Dr. Prof, one of the physicians working in the prison in Haiti, speak about the situation of COVID there at the National Penitentiary.
Thank you, Dr. May. The first COVID-19 cases have been reported in the National Penitentiary in May 2020. Despite the adoption of a contingency plan and the implementation of certain mitigating measures to prevent the virus from entering the prison, incarcerated people presented symptoms. It has been difficult for most of them to follow the measures. As of June 30, 2020, 62 people who have been incarcerated or infected with COVID-19 and 10 deaths related to the virus have been reported. Infected patients are being kept in an area that we had used to treat cholera away from the others. This area is already overcrowded and leaves no alternative space options for healthcare staff to treat other patients with emergency needs. The number of infections is far greater given the overcrowded, inadequate infrastructure, and irregular supply of food and essential medication to meet basic incarcerated people needs. The Ministry of Health does not have the capacity to test all of the incarcerated people or the prison staff, and so far just a few tests are done. The leader of the COVID-19 Response Commission said, at the present, the COVID-19 disease is so prevalent in Port-au-Prince that you do not need to be tested anymore. All patients presenting with the COVID-19 symptoms have over 80% probability to have it. So at the prison, some patients present mild symptoms of the virus, while others are in need of oxygen or hospitalization. They are treated with paracetamol as we send their tests to the national laboratory. Next slide, please. I will turn over to Karine Duverger so she can fill you in for the space in the prison.
Good morning, everyone around the globe. As you can see, we are fortunate enough that we already have the module that are donated to us by UN. We already have the space, as you can see on your left side on the bottom. This is the space where we already have ready. We can start the project. But definitely it's impossible to implement the social distancing, as you can see all those previous pictures with the overcrowded, system that we have in Haiti. Now, we do have the solution for the COVID treatment center at the National Pen, but it is unsolvable if we don't have those housing units. So we have everything ready to set up, to start the housing unit, but now we need to put together, I guess, get the fund to get it ready. But with that said, I'm gonna pass it to Mohammed and also Andrew, who's gonna give you guys and discuss the whole specific, the design of how we're gonna have those units right there on that space that we have here ready to go. Next slide.
Thank you, Kareem. As we indicated, the UN, the original thing that Steve talked about, we had talked about just using normal shipping containers. The UN had brought in a lot of containers as part of the earthquake response and donated 10 of those to help through walls and the country that can be used for this. We're basically looking at 10 modules 6 will be used for treatment housing, 1 for more secure treatment housing, and 3 for specialized use, an office, a clinic, and 1 as a ablutions unit. Mohammed?
All right, so we had the opportunity to really study what was necessary with the program breakdown, and we really, I'm sorry, oh, that was the other noise. Next slide, please. Andy, next slide. Oh, okay, so we had the opportunity to really study these building containers because we wanted to understand and maximize the amount of space for these patients. So we tried to identify, well, with this growing amount of positive cases, we wanted to offer an option with bunk beds and then actual medical units for those who needed to be separated from the population. And then we also provided the opportunity for a high security container for those that really did need to be isolated. Yeah. So with that, we also looked at other necessary programs like clinic space, the clinic space, program rooms, office spaces, and then separated from the rest of the, all of this really wanted to be its own entity separate from the rest of the facility, just so that we could maximize quarantine as effectively as possible.
So our intent is to be able to fit these up off-site to keep the cost minimal, to provide ventilation, to provide exhaust air, filtration for the exhaust air, and to maximize the capacity we could. A very limited site area. Basically, the thought is, as I said, 6 of these would be used as housing, which could range from 3 to 8 beds. Again, it's still not the kind of social distancing I think Jim showed in some of the things that have been done where people have a lot of space to simply set up a temporary facility, but it certainly provides much more ability to quarantine folks than exists in the current penitentiary. And then as you see the bunks in the middle, the thought is that by using a very, very simple covering, we can also create some outdoor space so that we can maximize the number of folks that we can take out of the general population to quarantine, if in fact they are infected and are symptomatic, to treat in terms of hoping to reduce the transmission in the general population. Mohammed?
All right. Yeah, so for those that did need to be isolated inside of the containers, we provide that option, and with the outdoor space in the courtyard, just so people could be able to circulate in, and we didn't want them to feel like they were confined and contained into such a small packed space, so we wanted to offer the opportunity for an indoor-outdoor public space. Next slide, please. And most importantly, to ease the tension of this tragedy that is going on, we wanted to have it be as meditative and as relaxing as possible. We wanted to bring out the themes of these calm and relaxing colors given these difficult times. We just wanted to promote the idea of a positive recovery. And what you see here is pretty much what it would realistically be with, given as a tight space, it's still a usable and feasible space for you to walk around in. Yeah.
So it's a combination of the ability to be able to separate people, to use it at different capacity, to maximize the capacity we could. And the good thought is long-term, Haiti hopes to replace, with the help of other countries, the penitentiary. These modules could be repurposed for the other prisons that were mentioned as part of what Health Through Walls is doing throughout the country. So the modules could actually be repurposed either in another prison setting or even to serve the community. And the real key to all this was to be able to do it off-site, to do it as inexpensively as possible, to do it using in-country labor, and to get to the point to where we're hopefully able to do this from anywhere from 2,400 to at a maximum $8,000 per bed that we're providing in order to help relieve the overcrowding and have the ability to separate this population. Robert, with that, perhaps you can talk about what we've been discussing in terms of the long-term impact of COVID on architecture.
Sure. First of all, can you hear me?
Yes.
Good. Okay, I'm speaking from Canadian Bush, and I found a signal, so hopefully it'll last. What we've heard today in terms of taking care of COVID patients, the best numbers occur when we have reduced numbers, and when we have to have people in prisons, we have single cells, and we introduce infection control measures. You know what? That sounds like a hospital to me. Within our practice, I've had the opportunity of designing acute hospitals, mental hospitals, prisons, forensic hospitals, schools, old folks' homes. And what's become very apparent is that there's a convergence of design. It's almost impossible to tell the difference between all those buildings I talked about. Because the needs of all those people, be it prisoners, patients, children, old folks, they're often very similar. It's just security that's different. What we see in front of us there is a prison. It's a prison for the Inuit. You can see it's small numbers, open spaces. You can't tell it's a prison. It was highlighted in Behavioral Health magazine, which is a psychiatric magazine, that even though it's a jail, it's better than 95% of the psychiatric hospitals in the States. Next slide. Next slide, please. Okay, this is not an old folks' home or jail, it's a school. The only reason it's here is, again, to show the convergence of ideas and respect. Next slide. That's not a school or a jail, it's an old folks' home. In Canada, our biggest numbers of COVID patients are the elderly because of suppressed immune systems. Go back, please. Okay, back to the previous slide, please. Yes, it's, these are for patients with dementia. They cannot leave. It's almost like an incarceration facility. But again, we can see here we're trying to get past the COVID element. The old folks one, please. By having single rooms, single washrooms, large association spaces. Can you jump 2 slides, please? This is also a prison. Well, it's a forensic hospital. People cannot leave. That's also a forensic hospital.
Yeah.
Is it my sound?
Next slide, Robert.
Yeah, well,
Next slide, Robert.
Okay. If you can go back one, please, Andy. Again, so this one and the previous one, they're both forensic hospitals. That is, people are incarcerated, they cannot leave, but they're there for mental health reasons. So be it acute reasons, COVID reasons, mental health, you can see that the designs are very similar to hospitals. Single rooms, ensuite bathrooms, healthcare professionals taking care of sick people. Next slide. This is a design for a jail we're working on right now. Same ideas. This is not a hospital, it's a jail. Similar ideas. Single level, single rooms, ensuite bathrooms, units no bigger than 32 individuals per unit. So again, convergence of ideas coming back all the time. Here we can separate populations for health reasons or for security reasons. Next slide. Another incarceration unit, but for youth. Same ideas again. Individual rooms, big spaces, ensuite bathrooms, a lot of light. Again, we're seeing these common themes coming all the way through. Next slide. This is a design for a hospital and a prison together. On the left side, it's a psychiatric hospital. On the right side, it's also a psychiatric hospital, but it's for prisoners. Same design for the prisoners and patients. So last slide. Next slide and the last slide. Here's what we've learned, okay? Smaller housing units, linear housing designs, preferably private rooms, ensuite bathrooms, large association spaces, normalization, give choice to people, color, security based on classification, healthcare environment, healthy work environments for staff, but it's all based on the idea that the provision of health should not be based on personal wealth or judicial disposition. Healthcare is a right. Thank you.
Thank you so much. I love that you end on that note. Thank you to all our participants and to our panelists. I'd like to save some, we have literally a minute or two for some questions. Emily, if you could spark them off. But I so appreciate that. And, you know, I'll leave with saying, I know that in the US, where there's also need for safe and healthy, clean facilities for especially caring for and monitoring sick, incarcerated people, the response has often been to has occasionally been to open up, you know, really decrepit facilities with asbestos and that have been shut down because they, in places even that are not overpopulated, they have been shut down because they were no longer needed and unattended to. They've now been reopened, and many incarcerated people tell us that, you know, that's just not somewhere anybody wants to go, and that causes people to make very hard decisions about whether they even want to report their symptoms, knowing that they would have to go to such a terrible place. And so I think, you know, these sorts of solutions that you spoke about in your modular systems are not only relevant to Haiti and places where you have built them in disaster settings, but also, you know, I think there's a broad applicability even to systems that are highly resourced with lots of space already, but very poorly cared for facilities. And this is a newer opportunity, if costs can be kept low, to really get people, even incarcerated in the US, access to cleaner, more sanitary, healing environments for COVID-19. Go ahead, Emily.
You know, so I'm cognizant of the time and we're at 11:30, so if people have to step off, that's fine. We've had a robust kind of question and answers on the side, and I really appreciate kind of the questions that are generated as well as our panelists for responding. There are two that remain, and so I thought we would just go ahead and address those in the time. One was directed toward Dr. Dretke. It was from Ebony Russ, asking that you had mentioned at the beginning of your presentation that the work that you guys are doing is collecting data at a national level on COVID prisons, rather of the incidence of COVID or kind of strategies regarding COVID in prisons and jails. And so someone asked if there was a specific study. And so I have to say I missed that part. I didn't quite hear it, and otherwise I would have responded to it. So I just turned that to you.
Thank you for that. No, it's not a study. The information that we're receiving are from these information exchange as we're doing. And we are trying to capture as much as we can, and with a vision that we can put some of it together, because from a lessons learned, best practices, just as so many of our panelists have talked about, there's some really, really strong positive innovations that should be models for all of us within all of our systems. So thank you for that.
Great. And I just wanted to echo that. You know, I think one of our real focus within the center and then with the conversations here is that undoubtedly we're living in trying times in a pandemic that wasn't, in certain ways, certainly wasn't predicted for 2020. And in no place in thinking about the care of incarcerated and then people with histories of incarceration is it more challenging. And I think the real focus, and I think how Dr. Dretke, how you introduced this, is that there are innovations, and even in the times of kind of despair or in these times of challenge, there are ways of really thinking about how we can anticipate and prevent and ultimately really improve the lives of those who are incarcerated. We have one last comment here by, I believe, Dr. Dreesen, Elizabeth Dreesen, and I think, you know, she, I presume she was hoping that there would be discussion about the effect of COVID on non-COVID medical surgical care for those people that are incarcerated, as well as for those that are in the community. She works at both a non-carceral hospital as well as within the prison system. And I think that's an important place, which again, we didn't cover on this webinar, perhaps another time, really thinking about how it is that given this pandemic, the kind of downstream costs of how it is that we care for those that are in our care in the prisons and community in more innovative ways. So I just wanted to, again, first off, thank each of our participants, panelists, for really sharing your deep expertise. I just want to thank the group also for kind of going along with us in our first webinar. And really, we tried to create a space where folks that speak Spanish and English could equally participate, and we'll get it right the next time. Unfortunately, our live translator actually is in Puerto Rico and without water and electricity at this moment. And so such is life, and we're infinitely grateful to Dr. Butler Delister for stepping in. But we next time promise to do better. I also just wanted to say that, of course, we had a panelist director from the Ohio Department of Corrections, and of course she was held up as directors are. And so there's a whole segment on monitoring the waste of correctional facilities as a really innovative way of anticipating and perhaps preventing, knowing when COVID is coming through. And so if there are slides to share or information, we'll be sure to send that along to all the participants. And I'll turn back, Lisa, if there's anything we've missed, and if not, we'll just close out.
No, we're grateful for everybody, and we hope that this webinar has fueled some ideas and has provided some concepts that people can take back to their home countries, home systems, be them correctional or community, to be anticipatory and really with the aim of protecting the lives of those who are incarcerated and those who work behind bars. As our last speaker noted, with the real overarching ethos that healthcare is a human right, and that what we have seen so far in COVID is that the health of people who are incarcerated has been really largely ignored. And so hopefully we have, our excellent panelists have given you some good concepts that you can take home, build upon, think about, email to ask more questions, and just spark some ideas. So thank you for joining us, and we hope that you all have a good day.
Gracias a ustedes. Gracias, General.
Thank you.
Gracias, General.
Un placer.
Thank you.
Bye.